Hey everyone, it's Dr. David, the ENT doctor. I just want to reflect on something which, at the time of recording this and putting it up, was a few days ago on my Facebook page, Dr. David McIntosh ENT, was a paper that came out from the Australasian Sleep Association, from a working party, who came to the consensus that a clinical examination of adults with obstructive sleep apnea was an essential part of the clinical workup. Now, I just want to pause on that moment and just give you some insight into how medicine works sometimes. So, I've got a PhD. Part of the PhD was that I went and did some historical research going back. Basically, it was on sinus surgery, and I was learning about how sinus surgery had evolved as a procedure. What I discovered is in the 1910s and the 1920s, there was some animal-based research that looked at how the sinuses work and specifically how the sinuses drain. And it was related predominantly to the sinus beneath the eye, which is the most common sinus that we would operate on. And back then, the traditional procedure was to make a little hole for the sinus, just at the bottom of the sinus, just sort of in there. And the premise was that if you made a hole at the bottom of the sinus, it could drain out. And that was the procedure. But someone then went and used some animal study models where they made that hole, but then they tested to see what would happen when things were put into the sinus to confirm, as they expected, that it would drain out through the hole. And it turned out that it didn't drain out through the hole. Within the sinus, there's a little conveyor belt, and it moves the mucus along, and it actually moves it to the drainage hole, which is the natural drainage hole, which is just up in there. And when they found that was the case, you would expect, quite logically, that they would understand how the sinuses would work better and realise that making a drainage hole down the bottom there is a waste of time. So armed with that knowledge, the sinus surgery did not change. Even though way back, 1920s, 1910s, they discovered that making a hole in the bottom of the sinus did not work at all. For the next 60 to 70 years, that procedure continued. In fact, there's even still people out there doing it still to this day. And it doesn't make sense. It doesn't work. So this is the problem that we can have, is that we can get stuck in our ways because that was the way that we were taught, and then the way that we were taught is how we then teach, and then that is then taught again. So just think about, the science showed that the procedure didn't work. 60 to 70 years later, still no change. So bear that in mind. Now, this is about obstructive sleep apnea though. And the way that we define in adults obstructive sleep apnea is by doing a test called a sleep study. Now, a sleep study is a complicated measurement system of breathing and heart rate and brainwave patterns and oxygen levels and carbon dioxide levels and all sorts of parameters to try and understand how someone is breathing, and also then try and understand how they are having trouble breathing. And way back in the 1970s, roughly when I was born, there was a person, or two people really, in the USA that decided to measure the breathing problem and then define some parameters that constituted when a breathing obstruction was significant. And they called a complete obstruction an apnea and a partial obstruction a hypopnea, as per certain definitions of duration and significance. And then counted those through the night and then divided that by the number of hours that someone was asleep to basically work out how many episodes per hour. The theory being that the more per hour, the more significant it was, and perhaps maybe some were normal, but then beyond a certain number was abnormal and then incrementally getting worse. And this was adopted and spread throughout the world. And what's interesting is that one of the people that actually developed this system later on said he wished he'd never done it. He came to realise that measurement system was flawed. And the very contemporary research coming out supports that it is indeed flawed. It's not relating very well to the problems that we would want to find. And I can only hope it will not take 60 to 70 years for people to change their paradigm and move on from the current measurement system. And basically, we need to build a better boat to help sail these choppy seas. The other thing, though, that I want to highlight, and this is reflecting back on this paper now, is a clinical examination of someone with upper airway obstruction has only just now being acknowledged as being important. Now, I like talking in analogies, so I want you to think you're feeling tired, you go and see your doctor, they do a blood test, and they find that you're anemic. Now, the gold standard, when we talk about medicine, we talk about the gold standard. It's just like we look at all the options, what is the best of the best? The gold standard management of someone that's anemic is a blood transfusion. Now, we have certain rules and regulations and guidelines as to when a blood transfusion is a good idea or not, but it is the gold standard. And the problem with obstructive sleep apnea is the gold standard that is promoted is something called CPAP, which is the mask pressure system. So if you were turning up to your GP feeling tired and they found that you're anemic, and they just basically said, look, you're going to be on blood transfusions for the rest of your life, and left it at that, you would probably feel a little bit despondent because you would want to know, well, why am I anemic? And in fact, going to blood transfusions, except in extreme cases, is not what the doctors do. They do manage the anemia, but they also know that they need to find the cause. And there's different ways that we categorise the cause, and they'll go exploring those options. So no one would accept a lifelong prescription of blood transfusions for anemia without an underlying cause being examined and assessed for. It's the same for obstructive sleep apnea. Obstructive sleep apnea is a disease of the upper airway. That is the territory that ear, nose and throat doctors are looking into day in, day out. We can assess the anatomy part of obstructive sleep apnea and basically break it up into levels. Is there a problem somewhere through the nose, either at the front, middle or back? Is there something wrong with the throat? Again, either at the front, middle or back. Is there something in the lower part of the throat? And again, is it around the voice box? Is it around the sidewalls of the throat? Is it the back of the tongue? We can look for these things and assess these things and work out what things are going on, and we can also use that information to help guide management. So, for example, if someone has a blocked nose, unblocking it is a really good idea. If someone has humongous tonsils, getting them out is a good idea. If someone has bad reflux and that is causing swelling in the back of the throat, treating the reflux is a bad idea. If when we're having a look, the person's throat collapses down, but when they bring their jaw forwards, it doesn't, then a mouth guard from the dentist may be a good idea. And the important thing to understand is that we should be definitely adopting and using the mask therapy, but it should be something that's used in the context of someone being optimized for success. And what I mean by that is that if someone has some form of physical blockage that an ear, nose and throat doctor can manage, we should be addressing those things. We should be getting those things out of the way. If someone has a throat that's collapsing, but it's better when the jaw is forwards, they should have the mouth guard in to keep the throat open. Now, patients that go through these things may still very well need to have the mask still, but they won't need the mask pressure so high. They may be able to cope with a nasal rather than a full face mask. It'll be more comfortable to wear, and we'll have a more likely success of people maintaining the therapy, because we know that only about 40% of people actually stick with the mask therapy. So, and a big reason that they drop out is because they have trouble coping with the pressure levels of the mask. And we can bring those pressures down, get things unblocked, get things optimized, but to do that requires an examination. And it should not be 2020 that we are finally coming to terms with the fact that a clinical examination of the upper airway for upper airway obstruction is actually a good idea. So of course I'm delighted to see that we're making this progress. It's something that I've been advocating for well over a decade, and it's something that we really now need to spread in terms of the paradigm shift that needs to come. There you go. Have a great day.